尊敬的各位同道，大家下午好。那么今天第一部分呢是邀请我们来自于菲律宾总属医院的Mendoza 教授。First, let's welcome the first speaker, Professor Mendoza. Professor Mendoza is a clinical associate professor. She's from Philippine General Hospital. Also, she's a fellow of APAGE. Today, she will talk about the research protocol of MITORStudy. Welcome.
Good afternoon, everyone. So I will be presenting the research protocol for the MITORStudy, which is entitled Minimally Invasive Therapy versus Open Radical Hysterectomy for the Management of Early-Stage Cervical Cancer. So we all know a couple of years ago, there was a randomized controlled study which gave us very shocking results, which showed that minimally invasive surgery for cervical cancer had poorer survival compared to the open surgery. And this was further supported by a large database study also released in the United States, which showed that there was poorer survival for the minimally invasive radical hysterectomy group. So this led to the question whether we should abandon minimally invasive surgery for cervical cancer. Hence, the APAGE, under the supervision of Professor Chilong Lee, came up with the study, the MITORStudy, which is a randomized multi-center prospective study, including all cervical cancer patients with early-stage disease that are amenable for surgery. So the treatment groups will be total abdominal radical hysterectomy versus total laparoscopic radical hysterectomy. The primary objective of the study is to compare disease-free survival and overall survival of patients with early-stage cervical cancer undergoing total laparoscopic radical hysterectomy and those undergoing total abdominal radical hysterectomy. And the secondary objectives will be comparison of the rate and characteristics of disease recurrence, the incidence of intraoperative and postoperative complications, the impact on quality of life, and the cost effectiveness between the two treatment arms. So this will show whether total laparoscopic radical hysterectomy is equivalent to total abdominal radical hysterectomy in terms of disease-free survival and overall survival. For the inclusion criteria, so the difference between the MITORStudy and the LACC trial, because of the new classification of cervical cancer released in 2018, we will be including all stage 1A1 patients with lymphovascular space invasion with 1A2, 1B1, 1B2, and 2A1 disease. Then, furthermore, in this study, we have extensively defined what a type 2 or type 3 radical hysterectomy or type B or type C radical hysterectomy should be. And the following are just the usual requirements for a patient eligible for surgery. For the exclusion criteria, we will not include patients who are not amenable for surgery, meaning they have advanced disease already. So these can be manifested through imaging or through biopsy of positive lymph nodes. Then we will also exclude patients who have already undergone previous treatment, including radiation. Okay. Of course, those patients who are not able to tolerate surgery or who are unfit for surgery will be excluded from the study. So central to the protocol is the study treatment. So the number one thing we have to do is to standardize the surgery. So in the paper, in the protocol, it was extensively detailed the order of the operation that is appropriate for cervical cancer. So it starts with inspection of abdomen and the pelvis, followed by bilateral pelvic lymph node dissection, followed by radical hysterectomy, whether it is through the abdominal approach or by laparoscopy. And the para-aortic lymph node sampling is at the discretion depending on the intraoperative findings. So in the protocol, we have extensively defined the steps for radical hysterectomy and the borders and the structures that we have to include in the specimen in doing radical hysterectomy. So very important is inclusion of the parametria. So the parametria has three components. So the ventral parametria, which is the anterior, the lateral parametria, and the dorsal parametria or the posterior parametria. So these are vital in having an adequate specimen for radical hysterectomy because this is one of the problems encountered in the previous study released in 2018. So for the outcomes, the primary outcome is comparison of disease-free survival and overall survival of the patients at 5 years follow-up. Then secondary outcomes include the rate and characteristics of disease recurrence, the intraoperative and postoperative complications, not uh, not not limited to urinary tract complications, lymphocyst and lymphedema. We will check also the cost effectiveness of the two treatment arms and assess the quality of life of patients with emphasis on the bladder and bowel function because these are usually the complications encountered after radical hysterectomy. So for the randomization, it has been designed as a 2:1 randomization with two patients assigned to the total laparoscopic radical hysterectomy to one patient to total abdominal radical hysterectomy. We have also come up with a random group generator. So this will be provided to the participating centers or surgeons in order to have an easier access for randomization of patients. So this has been designed as a 2:1 randomization. For the sample size, it has been computed that the study would only need 820 patients with 540 patients assigned in the total laparoscopic radical hysterectomy group and 280 patients in the open surgery group. And this will have a power of 90% with 95% confidence and two-tailed comparison. For the statistical analysis, since we are dealing with survival, so mainly we will be using Kaplan-Meier survival analysis. And then summary data will be used for categorical data. Okay. For this study, if the difference of survival is not more than 7% between the two groups, then the two procedures will be considered to be equivalent. So another point we want to emphasize in the protocol, aside from standardization of the procedure, is to have an accurate recording of the operative procedure. So a case report form will be provided to the participating surgeons or centers, and it's very detailed that they have to include the specific surgical instruments used, the use of a uterine manipulator, because this was one of the problems encountered in other studies that they said that the use of uterine manipulator contributed to having a poorer outcome for the patients who underwent total laparoscopic radical hysterectomy. So if the uterine manipulator is not used, it should be indicated. Okay. And then for the colpotomy approach, whether it's done by laparoscopy or through the vaginal approach, and then how the vaginal cuff is repaired. Also, in some countries, they have already adapted the no look, no touch method in doing the colpotomy, so they can also include that. And it would be excellent to include a photograph of the specimen post-op. So it's a good way to assess whether the margins of the specimen were adequate. Aside from those, in the case report form, we have to include the total operative time, okay, the blood loss, the intraoperative complications, the reasons for conversion to laparotomy for those patients assigned to the laparoscopic approach, and for those patients who underwent periaortic lymph node sampling, the operative time for the sampling should be also included. So from the start of the study, so once the patient is enrolled in the study, a written informed consent will be obtained from each patient and before any specific procedure, because at each point in the study, so whether preoperative, during the surgery, or during the follow-up period, there will be some tests or procedures done for the patient. So part of the informed consent is asking permission for those procedures. So we'll start with the preoperative period. So these are the minimum requirements for the patient. So a chest x-ray or imaging such as CT scan, MRI scan, or PET CT scan should be done. And depending on the classification of the patient, if needing to do 12-lead ECG. Then during the surgery, so I have already presented the case report form, so that is how we will document. And then at the post-operative period, so the visits 3 to 7, because visit 1 is the pre-surgery, pre-operative period. Visit 2 is the surgery itself. Then visit 3 to 7, this is week 1, week 2, week 4, and week 6. So as part of our primary and secondary outcomes, we have to evaluate the quality of life and other adverse events that the patient will report. Okay, so the imaging, such as ultrasound or CT scan, will be at the discretion of the investigator, depending on the presenting symptoms of the patients during follow-up. Then, at the 9th month period, because we will follow up the patients for 5 years at least, at the follow-up period, so during the first 2 years, it will be every 3 months, and during the 3 years after that will be every 6 months. We will do the clinical assessment, okay, and of course, we will ask for symptoms pertaining to bladder or bowel function. Pap smear result, Pap smear test at 9 months and 12 months, and imaging, okay, at 1 year after surgery and yearly thereafter. Chest X-ray also at 1 year after surgery, and the quality of life assessment form at each visit. For those patients who will have recurrence, there should be histologic evidence of recurrence. So a biopsy should be obtained, and this should be sent for histological confirmation. Also, the date of the recurrence, the location of the recurrence, and what subsequent treatment will be instituted should be included in the records of the patient. Then, if there are any imaging studies that will be done, should also be included. So all possible efforts should be done in order to have completeness of the records. And if it's very unfortunate that the patient will have demise, then this should also be recorded and included in the study. So for the quality of life instruments, we will be using three evaluation forms. The first one is specific to cervical cancer. So this includes certain aspects such as physical, the social, the emotional, and sexual function of the patient. And the other two also covers for the different aspects of the social function of the patient. Okay. For the adverse events, okay, this will be reported using the common terminology criteria for adverse events. So the latest version was in 2017. So this is also included in the case report form. So for the records of the patient, all the papers will be provided, and they just have to fill up the specific items that are related to the patient. Okay. And it's very important that the adverse events will be reported immediately to the trial committee, which I will be presenting later, because we have several committees that will be monitoring the study. Okay. So for patient withdrawal, it should be emphasized that all patients can voluntarily withdraw from the study at any time, and this will not affect their treatment. So once a patient withdraws from the study, it should be indicated in in the records and they will not be included anymore in the study. But these are the different classifications of the patients. Okay. For data handling and quality assurance, there will be 2 centers. So one will be in Shanggong Memorial Hospital and the other center will be in China for the participating centers in China. Okay, so another important tenet in our study is the accreditation of the surgeons and the centers that will be included in the study. So for surgeon eligibility for the open surgery group, the surgeon should have performed at least 50 cases of total abdominal radical hysterectomy and surgical staging for cervical cancer. And the same with the laparoscopy group, they should have performed at least 50 cases of laparoscopic radical hysterectomy and surgical staging. For the participating center, so it should be a tertiary institution where both open surgery and open radical hysterectomy and laparoscopic radical hysterectomy are performed. And these are the following conditions. So any of the 3 conditions that are met can allow the participating center to be included in the study. So they should have at least a history of performing 50 cases of total laparoscopic radical hysterectomy for cervical cancer annually, or they have a history of performing more than 200 cases in the whole time that the center was established, or they have published data on the excellent performance of the center and qualified by the APAGE Accreditation Committee. So as I was mentioning earlier, there are 3 committees that are integral to the study. So first is the APAGE Accreditation Committee. So they are mainly handling the accreditation of the surgeons and the centers. So these are our esteemed members. Then for the Trial Safety Committee, they will review the safety and efficacy data collected during the study. So the members will include 2 gynecologic oncologists who are not related to the trial, 2 statisticians who are also not related to the trial, and a member of the APAGE Gynecologic Oncology Committee. Okay. Then for the Trial Management Committee, so they will review and manage the trial's progress. The members are the study chair, Professor Chilong Lee, the co-chairs, Professor Ding Ma and Michelle Candice, and 2 study coordinators, Dr. Kwan Chen Huang and Tiching Liang. Okay. Okay, then we have an advisory committee by included are Professor Alan Lam, Professor Michelle Canis, and Professor Jeffrey Lin. Okay. So that's the end of the protocol, and we are hoping that you will join us in our study. Thank you.
Okay, thank you. Thank you so much, Professor Mendoza. It's a very nice talk. It's very detailed to talk about the why and how we start the MITORStudy. Later, I will take a second to translate the key points to the audience. And then we will have a very short question-answer time.
Okay.
Okay.
Okay, thank you.
Thank you. 那么我们首先非常感谢Mendoza 教授给我们特别详细的讲解了我们这个 MITORStudy 的这个研究的一个方案。那么在继2018年 LACC 研究公布之后，以及我们今年的 NCCN 指南将早期卵巢癌的微创手术治疗方式删除之后，引起了我们这个早期宫颈癌的那个手术方式发生巨大的变化。同时呢，也不管是在国内还是国外，都引起了巨大的一个特别激烈的争论。那么我们的 APAGE也就此展开过12条的一个分析。那么我们的 Mendoza 教授呢，在这个演讲当中重点提到了2点。第一点呢，就是我们手术切除范围的要求，就是我们可以用程教授的翻译，就是横向刀边，纵向刀底。那么接下来今天下午他也会具体的来讲解这个规范的一个术式。第二点就是对手术者的要求，Mendoza 教授提到呢， 就是手术者有2点要求，第一点呢就是取得配置的一个资质，第二点就是这个手术本人必须完成至少50例开腹的或者是腔镜手术，或者是这个中心曾经有过至少200例以上的宫颈癌的那个早期手术治疗史。我们再次感谢Mendoza教授。Thank you so much again, Professor Mendoza. And here's a question about the tumor size. It's what depends on of the tumor size, because sometimes the surgeons they see the tumor size is less than 2 centimeter, but finally the pathology they said is more than 2 centimeter. So about this question, what will you do in your hospital?
Okay, thank you for that question. So what do you mean, what will we do if the final histopathologic size is more than 2 centimeters?
Yes.
Okay. So having a size of more than 2 centimeters is considered a poor prognostic factor, but we also have to check if there are other poor prognostic factors, because if there are 2 or more, then we will have to give radiation with chemotherapy for the patient. But usually, yes, we have to combine the intraoperative findings and the histopathologic findings in order to have a more accurate diagnosis. So aside from the tumor size, we have to check if there are other factors that may lead to recurrence and if we need to give further treatment for the patient.
Okay, thank you. Thank you so much.
Okay.